So, Dr. Meiying Zhuang is an endocrinologist in Vancouver. She completed her MD internal medicine residency and endocrinology fellowship at the University of British Columbia, and she has a special interest in stem cell and islet transplantation for type 1 diabetes, and is currently completing additional training in this area with Dr. David Thompson, Dr. Bree Patty, and Dr. Bruce Verschere in and in her spare time, she enjoys dancing and going on adventures with her husband in their clamshell trailer. We are very lucky to have her here tonight to answer your questions about T1D islet transplants and current clinical trials. I will hand it off to her now for her presentation.
All right, thank you very much, Caleb. Nice to meet you, everyone. So I'm just gonna start sharing my screen. Okay, so we're good to go. Looks okay, Caleb?
Yeah, looks great.
Okay, great. So we're going to talk about the current options that we have in terms of clinical trials for stem cell transplant in type 1 diabetes today. And there's lots of time for questions at the end. This is going to be a bit of a whirlwind tour at the beginning, but happy to answer any questions you have. So just as a background as well, I wanted to show you guys the scope. So what we have in BC, besides the stem cell clinical trials that are happening right now, are also pancreas transplants and islet transplants. And this is kind of necessary background information, I feel, for you to really understand what the stem cell transplant is about. So I'll talk briefly about those two as well first. So pancreas transplants are essentially whole pancreas transplants coming from deceased organ donors. And the pancreas is transplanted either on its own, which is less common and usually done for young, healthy, otherwise patients where the surgical risk is reduced. Um, and more commonly, we see pancreas transplants done either at the same time as a kidney transplant or after a kidney transplant in someone who is already handling the major risk with the transplant, which is, besides major surgery, immunosuppression. We also have islet transplants. These islets are essentially the cells purified from deceased donor pancreases. And the goal of an islet transplant, we like to emphasize, although some may achieve insulin independence, this is not the goal, and we cannot guarantee this with islet transplants. Primary goal of an islet transplant is to help someone regain their awareness of hypoglycemia, meaning the feeling of hypoglycemia, of low sugar. So when diabetes progresses, especially when type 1 diabetes progresses, people may lose the ability to sense lows, and that can cause a lot of fear, for example, and worry about not being able to detect when you're going to have a low. And so that's a situation when even if we can't achieve insulin independence, having an islet transplanted actually does help people regain that ability to feel the lows again. And obviously, with this ability to feel the low, we expect a reduction in severe hypoglycemia. And we do see this severe hypoglycemia, meaning events of lows where you are not able to help yourself, someone else has to help you treat it. And then the other benefit that we see from these islet transplants is the slowing down of progression of complications. So, for example, eye disease, kidney disease, nerve disease in particular is what we have data for. Just a bit of a pictorial of the actual process. So after the pancreas is removed from the donor, the islets are isolated in the lab and put into an infusion bag. And this infusion is essentially infused into the main vein of the liver through the skin and through the liver tissue. And so with this, obviously it's a procedure that's going through the liver. There is a risk of bleeding. There is a risk of clotting because of the cells that are entering the vein of the liver. and any other procedural risks like infections. These are short-term risks that we are usually able to manage, and we have strategies to mitigate. And then long-term wise is risks related to immunosuppression, which is also required for an islet transplant because the cells are coming from a donor that is not yourself. And the islet transplant program is limited actually primarily by recipient compatibility, but there is obviously donor supply, and the process of islet purification is an important factor because of the time it takes and the ability to get pure islets and good quality islets and a high number of islets from a donor pancreas for it to be qualified as an acceptable islet for infusion. Okay. So how do we solve these limitations? So this is where the stem cell trials come in. And so we have a couple trials that are ongoing and we are recruiting for or will be recruiting for, and we're in discussion. So trials that have been run in Canada and some that are here include stem cell product infusion directly into the portal vein. So a very similar process to what is done with the islet transplants. The ones that have been run previously do still require immunosuppression. And then there are also trials being conducted currently where no immunosuppression, or at least long-term immunosuppression, is required. So one of these involves stem cells that have been genetically modified to evade the immune system or hide themselves from the immune system and prevent being detected. These stem cells are implanted into a small device, I'll show you in a bit, and surgically implanted rather than infused into the liver. And similar mechanism, but instead of the cells being edited, we're also working on a membrane that protects the cells from the immune system as well. So I'll go into these in detail. So as I mentioned earlier, in the studies where the stem cells could be infused into the portal vein, it's a very similar process to the islet transplant. Because it does require immunosuppression, there'd be similar risks. Previous trials have shown good promise for insulin independence with this method, and we'll have more information on this soon in terms of UBC's involvement. This is an earlier trial, the ViSite 210 trial that happened, where stem cells were encapsulated into a thin device and implanted subcutaneously in the abdomen area, just underneath the skin is what that means. And they were found to actually produce C-peptide, which is the marker of native insulin production. So not insulin from the outside, insulin injected by therapy, but insulin produced from the cells themselves. So at 1 year after implantation, we found that the cells were actually making their own insulin. So the current trial that is being run is a step beyond this 210 trial that I just showed you. And this one involves the same cell line as was in the previous one, but with additional genetic edits done using CRISPR. If any of you have heard of it, is essentially a gene editing technique to promote immune evasiveness. And the cells are able to hide from the immune system while still being able to produce insulin. And these cells are encapsulated into this thin pouch. It's a very, very small device, not thicker than a credit card. And essentially, this is placed into the area underneath the skin in a surgical procedure. So eligibility criteria for this study, which may be modified as there are some ongoing protocol changes happening still, but from the clinical trials website, which you can refer to as well online, age between 18 to 65, I believe this is one of the questions as well as the age for these studies. So age 18 to 65 is similar throughout. Type 1 diabetes for a minimum of 5 years, being on a stable diabetic treatment regimen for at least 3 months prior to enrollment in the study. People cannot have had any previous transplants or other gene therapy for any reason for this study. And they cannot have had more than two or more severe unexplained hypoglycemia events in the last 6 months. So low events where you were not able to help yourself in the last 6 months. And they cannot have any other reason to be on any other immunosuppressant drugs. So rheumatological conditions that may require immunosuppressants or any other reason for requiring immunosuppressants would preclude the person from the study. So of note, this study people would not be on immunosuppression for. Similarly, no immunosuppression in this other study that is going to be recruiting, the Vertex 264. This is using an immunoprotective capsule. So similar idea as the previous capsule, but this is a proprietary membrane that essentially protects the cells from the immune system while still allowing oxygen and insulin to flow. These cells have not been gene edited. Again, this device is going to be surgically implanted, and similarly, eligibility criteria includes age 18 to 65, type 1 for a minimum of 5 years, being on a stable diabetic treatment regimen, and consistent use of CGM as well for 4 weeks prior to the study, and being willing to use CGM or continuous glucose monitoring, such as Libre or Dexcom. The study will provide one for the duration of the study, and not having had any prior transplants. Just to say, both of these studies and other studies do have many other eligibility requirements that are confidential, but will be reviewed if you do screen or go ahead and decide to go ahead with the study. You will be reviewed for all of the eligibility criteria prior to entering the study. Okay, so this is my last slide. So if you are interested in these studies, we are recruiting, and we do also have a new clinic starting at the VGH Diabetes Center, where anyone with type 1 who might be interested in the idea of a transplant, not just these studies, but islet or pancreas, or if you're not sure about what's right for you, if you feel like your management needs some optimization, or if you don't have an endocrinologist, you have type 1, I will be leading this clinic, and we are happy to see patients and discuss these options for you in more detail and do a thorough consultation with you. So in order to go ahead with this, you would have your family physician or your primary endocrinologist send a referral to the VGH Diabetes Center for type 1 diabetes, interested in transplant specifically, and they would route it to this clinic. If you are happy with your management, but you're interested in participating in the study, please feel free to contact our study coordinator, Barbara Allen, and this is her email address. I will leave this information up for you. I'm happy to take any questions.
Excellent. Thank you for a very interesting and informative presentation. I'll get into the questions that were submitted beforehand first, which are kind of divided into sections here. The first being surrounding eligibility criteria. The first one is asking about age, which you did answer was 18 to 65. So I'll get into the next question here from Rhonda. I was diagnosed with juvenile diabetes at age 11. I'm now in my early 50s. Can I do this? So another one surrounding age.
Yeah, so definitely, obviously, we would have to look at the other eligibility criteria, but based on the age, there would be no reason that from the age-wise, if you're under 65, to participate.
Great. And the next one here is from Allison. I would love to participate. I tried to with a trial but wasn't the right blood. Is there hope for me to take part in the future?
Yeah, for sure. So some of these trials right now are requiring a specific blood type, but not all of them. And so I would just, if you're interested, reach out to Barbara again and see if there is one that you would be eligible for. Yeah, that's what I would say. Definitely hope in the future. And we have like these are the trials that I've talked about today are what are happening right now, but we are hoping to be involved in many more trials coming up in the future in Vancouver, and we would be a hub for BC. And so definitely there is hope.
Great. And
And even
Allison,
now, actually, I think you could check in with some of the other trials going on. Like the 211, I don't think has a blood type restriction.
excellent. Thank you. And Allison, did you want to follow up about that? All right. The next one here is from Anonymous, and it says, do you have to live in Vancouver to be part of the study? For example, I live in Alberta.
Um, Sorry. So you So if you live in BC, you can be, I think, part of the study through our center here, as long as you're able to come to Vancouver for the study visits. If you are in Alberta, actually, you can still be part of the study, but you would be probably doing it through the University of Edmonton group. They are actually participating in these studies as well, and they have a very strong islet program and clinical transplant program as well. So I would look into University of Alberta's islet transplant and clinical transplant studies because they are running. We're all part of the same group here. So.
And I just saw one comment on the chat as well that's on this topic, and it says, what about for Toronto, Ontario, if there's anything going on there?
Yeah, I do know that Toronto is also the Vertex studies. Toronto is involved with as well, and the CRISPR one, the CTX211, I'm not sure yet, but I think they are trying to have like a cross North America reach, and Canada is quite involved in these studies right now. And in fact, like Toronto is the one that has more patients in the portal vein study that was done so far. We happen to have in Vancouver done all the patients that were in the first group of the 211, but Toronto, Alberta, and BC, I would say and Vancouver would be the main sites. Toronto, Edmonton, and Vancouver, I should say, would be the main sites that are running these studies.
Excellent. Thank you. For our next question here and the last one in the eligibility criteria that were pre-submitted, it's a question from Alan. It says, I have applied for clinical studies in the past, but I've always been declined due to my A1C being below 6.5. Is this true for this study? And if so, what is the reason for it?
So I don't know if I can tell you exactly, but 6.5, exactly the range for this study, but 6.5 would not preclude you from at least some of these studies. I did see this question and double check. But essentially, I would just check in for any of the studies. I would check in again with the study coordinator because each study does have its own cutoff and will vary depending on the protocol. Typically, the reason for having a higher A1C cutoff, or usually at least 6% cutoff, is because if you think about it, in terms of collecting data, especially with these newer studies and newer interventions, if we're trying to look for an effect and you already have very, very good control, then it's very hard to see any improvement if someone already is very well controlled at baseline. And so often they're looking for at least some higher glycemia before to compare with.
Great. And Alan, did you want to follow up about that question?
Yeah, no, I guess that makes sense, from being able to measure whether it was successful or not. It just, something that I've been a little frustrated with, just because you try your hardest, and now when all these I think very interesting trials are coming up, I'm finding I'm not eligible because I'm even below the 6, right?
Yeah, and I mean, it's really good for you. I have to say, like, it's really good for you that like you've done like so well in terms of managing that. And to be honest, like a lot of these trials, um, I think we're at a stage where if you're interested in participating in the trials in terms of like promoting the science and having things going forward, I think like we would be so grateful to have your participation. At the same time, from your perspective in terms of your management, if you already have really good management and control and are not having issues with loads, you do have to think about like the potential risks involved with the um, trials as well. And if, for example, there's immunosuppression involved or the procedure itself. And so I would definitely weigh those as well. And if you already have really good control, like in terms of the risks and the benefits. But if you're in the sub 6s, then yeah, often I think, especially at this stage of trials, we're probably not necessarily going to see eligibility. Uh, Sometimes I do know in some trials, like sometimes people will loosen the control a little bit in order to become eligible, but that's kind of up to you and your endocrinologist to decide if you want to do that, and depending on how much you think the trial would be worth it for you, right?
Maybe just an add-on question, if it's okay. I've also been told that a lot of the studies that I can't remember if it was 60, but once you get over a certain age, then again you would not be eligible for the studies. Is that do you see that often for these trials that they cut off at an age?
Yeah, so the cutoff for these trials are at 65. Here. Yeah, so they're 18 to 65 for these trials.
Okay, perfect. Yeah, thank you.
All right, I will move us into our next section of the pre-submitted questions now. The first one being from Anonymous, and it says, do you recommend the transplant for older type 1 diabetics?
The stem cell transplant, is that the question, or?
Yeah, for the islet transplant section, it says, do you recommend the stem cell transplant for older type 1 diabetics?
So it's a bit of a nuanced question. So it's really, it depends on your situation, rather than saying like based on age, it's more like based on, so in terms of transplant pancreas or islet, or even stem cell, like the reason why I would think about someone as someone who would benefit from a transplant would be, as I mentioned, like if they have lots of severe lows, not feeling their lows, or they have lots of ability, or there are multiple complications from the diabetes, then in that situation, I would think that the risks of the immunosuppression and the procedure itself would be outweighed by the potential benefits with the transplant. And so that's kind of regardless of age. We do start to think, though, when you're reaching 70 plus, we do think about it a bit more in terms of like, what is your quality of life right now, and how much more can we improve your quality of life going forward? Like, how many more years? What is the overall picture? If you're like a very healthy, fit 70-year-old, then like obviously we're not saying, oh, 70 is a hard number as a cutoff, right? Like if you're fit and healthy, and otherwise, like we see that a transplant would give you much improved quality of life, then we would definitely consider it for you. And so we don't necessarily use that age as a marker of whether we would recommend or not. It's more of the clinical picture around the diabetes itself. And in terms of the transplant trials, the stem cell trials, again, there is that age cutoff there, which is the 65.
Thank you. And Anonymous, if you are on the call and wanted to follow up, I'll give you a moment to do that. All right. So our next question is another one from an anonymous member. It says, I'm currently privately storing my daughter's stem cells. Is it worth it since she's more likely to have T1D as a child of a T1D?
So this is, I saw this one as well. This is an interesting question. I'm assuming she does not have T1D herself, is what it sounds like from the question. Feel free to clarify. I I think this is sort of a more of a value judgment on your end. It's not something that we would necessarily routinely recommend. Obviously, there must be a cost associated, and you're able to do this, but um, I guess there's so many factors, right? Like we don't know if she would develop T1D. This if there is a chance in the future, maybe that we would be able to take those stem cells and um, derive beta cells from them. In fact, these stem cells for these patients, for these trials, are derived from human embryonic stem cells. And there's also studies looking at the cells directly derived from the person, their own stem cells, right? So actually their own skin cells backtrack to stem cells and then forward differentiated into beta cells. So there is value. There is a basis to what you're doing. I can see the basis to what you're doing. I just don't know how far how close we are to being able to utilize that technology on a mass scale. You may have your own access to those things. I don't know the cost of it to you. So it's something for you to kind of balance. I don't know if I can necessarily weigh in, but those would be my thoughts, is that it's possible. I'll just leave it at that. I don't know if that's helpful or not.
Thank you. And I will, if they are on the call, we'll kind of give them a moment to see if they wanted a follow-up around that question.
Hi, yeah, it was my question. Thank you so much. No, that was helpful. I was just curious if, it actually would be beneficial potentially in the future. And it sounds like there's hope. There could be. So, yeah, thank you.
Yeah.
Awesome. So our next question here is from Therese, and it says, where do stem cells originate? Will the clinical trial participants need to take anti-rejection drugs?
Yeah, so as is kind of like nice segue there. So yeah, the stem cells do come from, so there's depending on the trial, some of them come from human embryonic stem cell, a bank of stem cells, and some of them come from what we call induced pluripotent stem cells, or they are from a donor cell line, which is like a skin cell, for example, that's backtracked and then forward developed, and it's also a stem cell bank. So that's the nice thing with these trials, and the idea behind them is that we would essentially have like an unlimited supply of cells to transplant if this was successful. And then I think the second part was also answered in the presentation, but remind me what that was again.
It was, will the clinical trial participants need to take anti-rejection?
Yeah, right. So it depends on the trial that you are a part of, but there are some running that do not have anti-rejection medications in the protocol.
Right. Great. Thank you. So our last one here in this section, it says, oh, it's another anti-rejection drugs question. It says, if not covered in the presentation, will anti-rejection drugs be needed? And if so, what are the side effects of those medications with T1D?
Yeah, so great question in terms of the side effects of anti-rejection medications. So like side effects in terms of short term would be often people experience fatigue, nausea, vomiting, um, headache, tremors, hand shaking. Obviously, it depends on the drug itself, but the common ones that we use, and toxicity to the kidneys. In the long term, there is an increased risk of skin cancers and blood cancers in particular, as well as an increased risk of sorry, as I was going to say skin cancers and blood cancers, but in terms of the transplant itself as well, the other thing to keep in mind, there is an additional risk, which is of the transplant. And when you get one transplant, you essentially, for if it's not a stem cell, but it's like an islet, for example, you are being exposed to another person's antigens and a foreign exposure there. And so your body develops antibodies. And each time you have a transplant, you have a reduced chance of potential matching to transplants in the future. And so that's something that we do consider as well, particularly if you have any degree of kidney damage already, then and like there is a chance and you're still young, let's say if there is any chance that you may need a kidney transplant in the future, then we would maybe be more cautious about doing an islet transplant right away, depending on what those antibody levels are like in your body. For the stem cell trials, that's not so much of an issue, but of course the immunosuppression risks are there. And so that's why, as I mentioned earlier in answering a question, like weighing the risks and benefits is very important.
Great, thank you. And if Anonymous is on the call and wanted to follow up, I will give you a moment to do so. All right, so our last question from the pre-submitted ones, and then I'll move into the ones that were put into the chat, but it's another one from Anonymous, and it says, how much progress has been made on islet transplant research between UBC and the University of Alberta Hospital?
Definitely a lot of progress, both in the bench research side of things and actually I would say particularly in the bench research side of things, such that we're now able to see these trials translate into the clinical phase. And all of these trials are really like in the realm of first in human trials for these devices and for these cells. They've done a lot of animal studies, not just UBC and U of A, but there are big groups studying this both at both of these universities, but across the world looking at this and furthering the progress there. And so I don't know if I can quantify how much progress, but definitely ongoing research is being conducted. There is as some of you may know, there's the JDRF Center of Excellence at UBC, and there's some research based in Edmonton as well, but Vancouver is the main center for North America. So we do have a lot ongoing here.
Excellent, thank you. So now moving into our kind of the meeting chat questions, I do have one that was a direct message, so I'll just say it from Anonymous for now, and if they want to follow up, I'll open that up for them. But why is 5 years diabetic a requirement for eligibility?
I don't know if I know the exact reason for that, but part of it, my guess is that, especially early in diabetes, people can have a honeymoon phase, or they can still have some C-peptide production or insulin production on their own. And we really want to compare to a baseline of essentially 0. So most of these studies do require that the C-peptide production, or when I say C-peptide, essentially like insulin on your own, production is essentially 0. And so that's probably the main reason, and to make sure that we are looking at later stage diabetes.
All right, thank you. And did you want to follow up on this one from? No. All right, the next one.
Maybe just a quick piece there. If you are interested in studies for like early type 1 diabetes, or if you've like just been diagnosed with type 1 diabetes, there are a couple of prevention trials as well ongoing. And there are studies that are run specifically for like patients who have had diabetes for less than 5 years or less than 1 year, right? So if you're interested in that, you can definitely look into it. And I do know that Dr. Tom Elliott's clinic, BC Diabetes, I work there as well. He actually runs a couple of these prevention trials, so something to look into if you're interested.
Excellent, thank you. So the next one here is from Susan in the chat, and it says, how long do the trials for VX264 or CTX211 last?
Yeah, so they're both different, but generally at least a year for the implants, and then depending on the trial and the protocol, if there's been any updates, that's often they'll then follow up. So it's between a year to 2 years, and then they will do a follow-up afterwards for 2 to 5 years.
Right. And Susan, did you want to follow up on any of that? Great. Awesome. So our last one here is, how important are indicators such as blood pressure and heart rate for these studies?
A little bit important in that, so I would have to look at the detailed eligibility criteria, which I can't necessarily divulge, but in the sense that certain complications would probably preclude you from the study, and if you had very high uncontrolled blood pressure, then that would probably be an issue, but it's not, I don't think it's one of the key criteria, so it would I don't think that would necessarily be, I don't think that's the reason for you to not reach out to find out more, is I guess what I would say.
Excellent, thank you. And Narm, did you want to follow up? Oh, they said thank you in the chat. And then just one other direct message regarding kind of the trials going on for people that have been recently diagnosed. They were wondering if you had any links or any information surrounding that where they could look into it more.
I would go to the BC Diabetes website and start there. I don't have the links offhand, but I know, for example, I believe the Biomea study is one of the ones that they're running right now, and it's an interesting one, but so it's spelled BIOMEA, I believe. And then the BC Diabetes website may have more information on that as well in terms of what trials they are running. They have a pretty thorough website.
Excellent. All right, so that wraps up our Q&A live discussion, unless anyone wants to ask any more questions before we go into an announcement and then some closing remarks. All right, so we do have an announcement for the JDRF directory. JDRF launched the Mental Health plus Diabetes Canada directory, launched September 2023, and is actively expanding. This directory is intended to provide people living with or affected by diabetes with access to information about registered mental health providers. These providers have engaged in additional training to understand the reality of living with diabetes in order to provide mental health support specific to addressing the realities of living with diabetes. Each mental health provider included in the directory has successfully completed the Mental Health plus Diabetes training program. The training program provides knowledge and tools to help registered providers deliver the best support to their patients with diabetes. It was developed by a steering committee made up of diabetes and mental health experts from across Canada and people with lived experience of diabetes. It includes 6 modules that covers diabetes basics, diagnosis and adjustment, diabetes management, transitions, complications, successes and challenges, and the role of the mental health provider. So I will put the link in the chat for you all right now. There we are. And for some closing remarks, a huge thank you to Dr. Meiying Zhuang for leading this month's Huddle and sharing her expertise on the latest clinical trials happening for T1D Islet transplants. Thank you everyone for attending tonight. We really hope that you enjoyed the session. We are continuously working on improving the Huddle sessions, and we'd love to hear from you. So if you have 5 minutes to spare, please consider filling out this short feedback survey. We look at every single comment, and your suggestions help shape the Huddle. I believe that Soraya has posted in the chat, or will, for the Qualtrics there. And if you have trouble accessing the surveys, you can contact our Huddle coordinator, Soraya, who has been sending you emails. Thank you, everyone.
I did find a link to the research page for BC diabetes, so just pop that into the chat if anyone is curious.
Excellent. Thank you.